I'm Shanthini Naidu, the CEO of the St Vincent's Curran Foundation, and it's my great pleasure to welcome you here today. Today, as I introduce our panel, I think you'll be impressed by their credentials. Dr. Aengus Tran is co-founder and CEO of Harrison.AI. Dr. Tran is a medical doctor, a world-ranked AI engineer and data scientist, and has a number of accolades, including being listed in the Daily Telegraph's top 30 tech entrepreneurs under 30, Forbes 30 under 30 in Asia, and regional finalist in Bill Clinton's Hult Prize Social Enterprise Competition. As CEO and co-founder, along with his brother Dimitri Tran of Harrison.AI, a clinician-led artificial intelligence medical technology company, Aengus and his team have rapidly developed breakthrough AI software across IVF, radiology, and soon pathology. So I'm sure you'll all be very happy, especially the clinicians here, to hear from him. But we have a special connection with Aengus because I believe that earlier in his career he actually did a placement at St Vincent's Hospital. So welcome, Aengus. Associate Professor Namasivayam is Staff Specialist and in Cardiology and Associate Director of our Echocardiography Department at St Vincent's Hospital, Sydney. He's faculty and lab head of the Heart Valve Disease and Artificial Intelligence Lab at Victor Chang Cardiac Research Institute, Sydney. Mayo, as he is fondly known to all of us, manages patients across the spectrum of cardiovascular disease and plays a key role in cardiac procedural imaging and planning that process across St Vincent's Hospital. And last but not least, Professor Stephen Faux, who's a senior rehab physician, director of our pain unit pain management unit at St Vincent's, and co-lead of our long COVID clinic at St Vincent's Hospital, Sydney. As well as being one of the first Australian doctors to establish a long COVID clinic, he's also established the longest and continuous telehealth pain management service in Australia since 2008. He's undertaken research in almost every aspect of virtual reality in stroke rehab and pain management, and completed the first Australian data linkage study in traumatic brain injury and stroke rehab. And finally, I'm delighted to welcome back our very good friend and supporter, Katrina Strickland, the editor of The Good Weekend, as our facilitator this morning. As you can imagine, with someone of Katrina's profile, she's been extremely busy in the last week alone, and so we're very grateful, Katrina, for getting up so early and being here with us today. Thank you.
Thanks, Shanthini, and welcome everyone. I don't know about you, but I feel like AI is absolutely the subject of the year. Overnight, there's been an AI Safety Summit in the UK, which has got the UK, the EU, China and US signing up. And I think the fact that it's called a Safety Summit says a lot. It kind of shows that we're all worried about the guardrails because of what's happened with technology in other areas where, we've leapt ahead and it's been amazing, but then there's been other downsides. And I think there's no area more important than health in which we kind of want to get the developments, but also, understand where we should put the guardrails. So welcome. I think we're going to have a fascinating conversation here today. Welcome, Aengus, Mayo and Stephen. Stephen, we might start with you. Your area is pain management and you're looking at AI in rehabilitation. Tell us, first of all, what you do essentially and why you went to AI and then how you're using it.
I think my role in rehabilitation is to identify people who have been injured or get sick and come to hospital who are going to need rehabilitation to get themselves back to work, driving, and their families. We used AI essentially because of industrial issues and the fact that we don't have enough doctors and too many patients. AI allows us to make our doctors work at the top of their scope. So it means that they don't have to do the day-to-day things, they only have to do the things that are hard and have to think hard about stuff. So, for example, in rehabilitation, there's about 300 people per week that get admitted to the hospital. 15% of them are going to require rehabilitation. But we can't see 300 of them to work out which it is. So we have developed a series of an algorithm which can be identified by a ward clerk from the notes. And we've been researching that, and we've found that if you answer 5 or 6 of these questions with yes, then there's an 88% chance that you will need rehab. And if you answer them no, there's a 97% chance you won't. So this means that we suddenly didn't have to see 300 patients, we only had to see about 60. And that was much more doable. So the problem with AI is it needs a lot of data. So for 2 years we entered over 2,000 bits of data so that we got those statistics, and now we've been given a grant by HCF to run it in a few hospitals in Sydney, some in the private, some in the public, and we're hoping that we'll have another 10,000 bits of data. So once we have that, then we can move on to automating it. Our only problem is that we don't have a really fantastic electronic medical record yet. So it's a work in progress, but the work for AI takes time, and I think we've started the bedrock. So that's how we've used AI in rehabilitation.
That's really true though, isn't it? If your technology systems are not up to date, you're not going to be able to maximise it. What's the risk of AI getting it wrong in that assessment?
Well, what we've decided, I think the thing about AI is that it'll be good at identifying things but not great at context. So an example I give is if we are told to see somebody because they had a head injury and they lost consciousness for a day, and we've been asked to see them. If on day 3 or 4 they're walking around and they're okay, and we see them and we find out, they've had a head injury because they were playing football and they got hit in the head, and they're recovering well and they've got a good family, well, they probably won't need rehab. If they've had their head injury because they've been involved in domestic violence and they've been sexually abused at the same time, they're definitely going to need rehab. And that context, I think it'll be very difficult for AI to get context. What it'll give us, it'll say these people are worth seeing, and then you'll need human beings to sort of create context.
And then what's the cost? Is the main cost of rolling this out in updating your technology, or your own overall system?
The cost of rolling it out, I think, is going to end up being the cost of making electronic medical records. But the cost saving is that we found that if we brought rehabilitation to people earlier, we saved 10 days of beds. So if we started rehab, they would discharge 10 days earlier than if we waited for another week or 10 days. So that saving is about $1,500 to $2,000 a day. So one episode of care could be saved $20,000 or $30,000. Well, that's plenty of money to get an electronic medical record with 300 patients a year.
And then what area do you lose jobs in as a result, or do you not? You just...
I think that's a fallacy. I think you don't lose jobs in AI. I think you make those jobs work at the top of their scope. I think there are all these people, clerks and things like that, who do really mundane stuff, who shouldn't be doing mundane stuff, who should be doing stuff where it's a bit difficult. And so I don't think people will lose their jobs. I think they'll just have to work differently.
And I'm going to ask everyone this question because it often brings out a good thing. What keeps you awake at night about this? What's the one bit of it that worries you?
I think the thing that worries me is that people are going to think AI is set and forget. they're going to say, I've got AI, so I don't need to look at an X-ray anymore. I think that's what worries me.
Right. And we'll come to you next, Aengus. Aengus won an award this week. So tell us what it was and what you won it for.
So at Harrison.AI, what we're looking to do is scale the capacity of diagnostic and treatment globally through AI automation. And that's based on a bit of an observation that it takes a long time to train clinicians. So I was trained as a doctor here in Australia. It takes about 6 years, right, out of high school to do your medical training, and then probably a lifetime of practice to become good at what you do. Medical training is almost like an apprenticeship. It's less like a professional role. It's, even in the language, right? You do an internship and then you become a resident, a registrar. So it's a one-to-one training piece. So it takes roughly about, say, for a radiologist, 14 years for a system to produce one. Meaning that, if we want to ramp up capacity of diagnostic and treatment, and the government say we put all the money into training, it's all free, we'll see the impact of that over a decade from now. And that's the huge problem for us. When the growth of the demand of those scans are coming up. In many ways, the tap of the demand of cases for radiology and pathology is filling the tank faster than we can empty it. And that's result in backlog. So most hospitals around Australia recently published in the news as well have a growing backlog of diagnostic cases. What it means to everyday people is that you take longer to get your critical diagnosis, longer anxious wait. But when people do look at it, they are rushed into looking at it. So a chest X-ray now take on average 20 seconds to read for radiologists. It used to take minutes, right? People used to spend a long time on this thing. I'm not sure about you. I like fast food, but not fast radiology. It's very scary actually, and sometimes it do result in misdiagnosis. So what we do at Harrison is we make an observation that one of the key technology of our time that can solve this huge challenge is AI automation. And the reason for that, and the reason why we're also excited about AI, is not necessarily the accuracy or the detection, but the scalability and ability to address that capacity. So over the last few decades, there's big investment in technology and computation power. So we now have, as a civilization, this almost limitless resource, right? Unlike material, gold, or human resources, computation is not really limitless, but practically limitless. Meaning that whatever technology you can develop, you can put a giant server behind that, and it's practically limitless. That's why we are so excited about AI, because if we can build that algorithms, right, something that's capable of, say, chest X-ray analysis or CT brain interpretation, or that cancer diagnosis, we can plug that into that limitless capabilities and able to solve one of the critical challenges of time. So that's exactly what Harrison is doing. We're building a fleet of algorithms that can automate the diagnosis and reporting of some of the big diagnostic area like radiology and pathology, and it's being used pretty rapidly here in Australia, but the world as well. So the award was for some of those great work that the team at Harrison has done recently.
And you were telling me before, which I thought was fascinating, that when the AI does a radiology assessment and you give it to the radiologist, the outcome is worse than if you give it straight to the clinician.
Yeah.
Tell us about that.
Yeah, so everything we built is a medical device. It's just because this AI doesn't excuse it from being a tool for clinicians. So as part of putting the product in market, we need to run this giant clinical study, it's called READER study, where we essentially found 2,000 chest X-ray. We get the AI to read it by itself. We got the radiologist to read it by themselves. And then we got the radiologist to read it with the AI assistant. So it's a 3-arms comparison. So the result came back, unsurprisingly, the AI did really well. The radiologist using AI did better than the radiologist who didn't use AI. But most importantly and most strikingly, the AI by itself did better than the AI with radiologists. So what we found was, in many cases, by showing the result to the radiologist and ask them to review it, for example, AI may say there's a rib fractures here or there's a lung cancer here. The radiologist look at it, overruled it, and on average, it's more often wrong than not.
Right.
So we now cross this sort of accuracy barrier threshold where in at least some clinical settings, some defined tasks, it's probably not such a great idea to overrule the system. But that doesn't mean that we shouldn't have the radiologist there. There's still other things that require doing, like top of scope practice, where they need to put in the context, they need to manage the patient. But maybe for that visual interpretation of what's on this image, where's Waldo, we should probably let the AI do that.
And so do you think that radiologists will one day people won't be training as radiologists, or there'll be a much smaller number of them?
I think.
Can you see a day where that job kind of almost is gone?
I think what is certain is the job will almost certainly look different than what it is look like today. So today, as a radiologist or as a clinician, if for the matter of fact, you're trained to look at X-ray and produce interpretation. It's like, what is in this image? Even though you really hope to be able to do the problem-solving part, which is what's wrong with the patient, what needs to happen next, that's not the majority of your day. And no one wants that, including the radiologists, right? If you ask most people, they're quite burnt out, it's tedious, it's boring. In the future, I see a world where all those interpretation is automated away with AI. You open up the X-ray and the report is written, if you like. And their role then is to decide, now what needs to happen? In a similar way to an accountant no longer needs to sum up the Excel sheets, but to draw insight, right, and to make recommendation. I see similar shift in radiology, but also other diagnostic area as well.
And does AI, or is the holy grail 100% accuracy? Because I would imagine even if you're 98% and the machine gets it wrong, and there's no one kind of looking at that, that's a big problem.
Yeah, I think there would never be 100% accuracy in any system. We can get multiple nines of accuracy. So some of our findings, we have over 5 nines of accuracy, meaning that 9.9999 accuracy, but we won't get necessarily to 100. But what's important to realize is so neither the human system, and in fact the human won't get to those nines of accuracy. And as a society, eventually we need to just form a risk-based view on this, and recognizing that there's always going to be that gaps, like anything else in life. So I think that's necessarily not the reason not to use AI due to those cases of accuracy. What we do need to focus on though is making sure that when you do get it wrong, it's not getting it wrong in a systematic way, right? In a way that bias or disadvantage certain population, and I do think that is a very real problem to solve.
And how do you look at, because it's all about the data that goes in, isn't it, in that respect? What are you thinking about to try and solve that bias problem?
I think the only way to look at this is the usage, right? So for instance, is there a subpopulation of 20-something years old X-ray in a Pacific country with a Pacific X-ray machine that the AI just systematically fail on? Like that is the risk. And the only way to flush that out is systematic usage, but also post-market surveillance. So every medical device, require post-market analysis. So we spend a lot of time making sure that we build in the pipeline to collect those feedback after we've deployed the AI tool to analyze this pattern and provide patches over time. So our AI tool, our chest X-ray tool, is being used by a third of all radiologists in Australia. It's being deployed in NHS, Asia, and we just got FDA clearance, so just turned on a couple of sites in the United States as well. So we're getting millions of usage a year back, and we are, it's on version 3 now, right? So every year we sort of keep patching it. And I think there's a diminishing return on that eventually, but I feel that's the only real way to solve the long tail problem.
And I know it will save costs down the track, but is the capital investment in the beginning very high for hospitals? Like, do they need to raise a whole lot of money to bring this in the first place?
So an average deployment of our system for an annual license is half of a salary of a single radiologist.
Wow.
And that AI system will address all radiology scan on a specific modality like chest X-ray at almost infinite volume because of the scalability that we talk about. So the cost equation is never been the question. It's really is that that process that we do need to go through. And I'm glad you talk about AI safety, because I feel like AI in health is one of the best regulated AI of all of the other industry. Just a matter of fact that it's being regulated as a medical device, right? So there's performance threshold you need to prove. There's burdens on commercial companies to justify safety and efficacy, and quality follow-up post-deployment. So I think, of all of the AI in use, like health is probably the safest AI, if I have to put
Because
it.
they already exist.
Because there's
Yeah.
TGA, FDA, CE who regulate this stuff. So, I don't really think that regulation is necessarily a bad thing here. It's quite clear, right? We say you have to deploy something safe. You need to make sure it continue to be safe over time, like penicillins or like a tablet. So I think it's not necessarily something new here, and perhaps other industry can learn from how health has done it for the change. Probably one of the area where health is leading the way in innovation there.
And then I'll ask you the same questions that I asked Stephen. What keeps you awake at night worrying in this field?
I think what really keeps me up at night is is that sweet cheese model that we talk about. We know that on average, over millions of cases, the AI should do better, right? And I feel really good about that at night. That's what put me to sleep at night is knowing that on average we are reducing misdiagnosis of cancer, by a certain percentage, and that's statistically provable. But there's this edge case, that require context. There's specific population, maybe a new X-ray machine coming out that introduce, this fluctuation that result in failures, and that's what keep a lot of our AI engineer engaged in solving that problem. But I do think it's a tractable problem that over the course of our lifetime we will almost certainly solve, and that's a real problem that we'll keep working on for a little while longer. Yeah.
Okay, thank you. Fascinating. And Professor Mayo, so hearts are your area.
Yes.
Tell us what you do and then how you've brought AI into it.
Sure. So my area in cardiology is specifically focused on cardiac imaging and heart valve disease. So heart valve disease is a major problem. There are a lot of unanswered questions in heart valve disease. One of the key questions is the exact point at which to treat someone and the true severity of someone's valve disease, because we have approaches to make those decisions currently. We have a weekly meeting, Professor Fenley and I go to, where we all sit down as a department of cardiologists and cardiac surgeons, and we review complex cases and we debate each other about whether someone should or shouldn't have cardiac surgery or minimally invasive valve intervention, and is it the right time, is this the right strategy? And that's because there's a lot of uncertainty. At the same time, we have reams of data about these patients, particularly volumes and volumes of images for them, cardiac images. And we know a lot about them, and we also know what happens to them longer term. If we can marry those two, we can identify using that baseline data who is most likely to progress to more advanced disease, who's going to do well with therapy, at what point in their disease trajectory. And therefore, our aim is really to use the realm of data that we have to make better decisions for patients about optimal timing for heart valve disease.
And do you have enough information currently, or do you have to change how you gather the data on patients for this to really work?
So I think we have good infrastructure in terms of digital storage of imaging. I think one of the things that has already been raised is medical records, if they're in one format which is not electronic, that makes things more challenging. But we do have ways of getting around that. For instance, a lot of our things like length of stay, diagnoses are still captured in electronic servers. So we can work to sort of work around that. But there's a lot of untapped data within the health infrastructure that just sits siloed away. It doesn't talk to each other, and there are different data custodians. And I think the challenge is bringing that all together to paint a cohesive picture.
And is that one of those things that everyone says should happen but never happens because of bureaucracy?
Yeah, I think to be clear, there's definitely a lot of red tape problem. But I think that increasingly organizations are understanding the value of this. and the value
But it's
across...
a big job, isn't it, to bring
It is a
records
big job.
together?
It's not easy,
Yeah.
but at the same time, computationally, it's an easy job because all the data are stored as zeros and ones. You just have to link them together. It's more making sure that everybody's happy that the different data custodians can merge their data sets and host them securely and safely. And you can understand to some extent the concern about it because it's health privacy, it's health information. Everybody wants to tap into it, and it has to be done in a careful way.
Yeah, because a lot of people didn't sign up to the federal government's
Yeah.
system in that respect, so that could be an issue, couldn't it?
Exactly,
Yeah.
because I think it's an emerging space, and I think one of the important areas in AI as a whole, but particularly in healthcare, is trust. And I think that's trust on both sides of the equation. Trust as a consumer, as a patient, trust as a clinician delivering care.
Yeah. We talked just at breakfast about how AI might be used in remote Indigenous communities, given that we know how poor the health outcomes are and how much heart issue is huge.
Yeah.
Tell us how you could envisage AI really helping, that big problem that we've all been debating in recent months.
Yeah. So I think that's a great question. And as we talked about, I think there are two aspects to that issue. So I think issue number one is when you develop these algorithms, you're using realms of data that already exist in the system. If that realm of data represents one group or a couple of groups of the population that live, say, in urban areas, that engage regularly with the health system, that can afford to do so and have the access, that's what your algorithms are going to understand, and that's what they're going to make their decisions on. And so there will be elements of the community that don't have that access or who don't have those opportunities who won't necessarily be represented. And we see that playing out in other divisions of AI applications where decisions are made based on sort of segments of the community. So that's one challenge we have to address. The flip side of that is we know that heart valve disease, for instance, is a significant problem in the Indigenous community, primarily driven by things like rheumatic fever. And there's a huge opportunity to improve engagement with health services through things like telehealth. So an example would be, for instance, right now, we run some heart valve interventions that are not run anywhere else in the States. Some are not run anywhere else in the country. For patients to come to us to have those procedures, they have to travel a long way, they have to have accommodation. Similarly with our heart transplant program, we're the only center in the state that does cardiac transplant or artificial heart insertion. So for patients to have access to that care, a lot has to happen logistically, even for just clinic visits. But if you can have a system that can analyze their data, flag patients who are at risk of deterioration in their own community, where they don't have to travel, they could be anywhere in the country, that opens up a world of possibility if you have centralized hubs with AI expertise, of which St. Vincent's could be one. The other possibility, moving more broadly and thinking more broadly as our role sort of in the Asia-Pacific region, is you could do the same for countries that have very poor access to care. So if you have data infrastructure to support remote diagnosis, for instance, you could have a very broad reach through centralized hubs.
Yeah. And what keeps you awake at night?
Well, I had an answer to that, but I've revised it based on the discussion here because to my left, Stephen told me AI wouldn't replace jobs. And then a couple of minutes later, to my right, Aengus told me that not only is the AI better than me, it's cheaper to the hospital. Look, I'll tell you what I worry about. I think we're at the interface of we're at a huge transition point, I think, as a society. And I think a lot's been made of it, and there's a lot of commentary about it. But I do think we are at a point where our society, even in 10, 20 years, will be considerably different to how it is now, solely due to the advent of AI and the impact of that technology. And I think when, in the past, you've had huge shifts in technology like this, it has created a lot of issues for us as a society. Some of them have been amazing, and our society has always progressed, but there have been periods of great challenge. And I think that's what I worry about. I worry about how this impacts global humanity. And if
you look at, say, social media and the mis and disinformation problem, we don't know how to solve it. We create it and then we can't fix it. So we're lucky to have in the room today Professor Michael Fennelly, who is the head of cardiology at St Vincent's, and also Ricky Sutton, who's been a patient. We might just hear from each of them very briefly. Michael, where do you see AI as being the most useful in cardiology?
Thanks very much. Well, look, I think it's going to make a huge difference, and I was very across all of medicine. One of the challenges, and Angus has spoken about, I was interested. Many people looking at AI for volume are looking in areas like radiology, for example, where you can do mass evaluation of a static image like an X-ray, for example. Or in dermatology, where you can use photographs of the skin. Again, it's static, two-dimensional, planar image. And I think in histopathology, we are currently talking very carefully with a great researcher in the States who is looking at replacing our need or doing a better job of analysing the histopathology of heart rejection after a transplant. In each of those cases, you have a planar image or a series of them, and it's sort of quite easy to understand intellectually that AI can do a lot with that. One of the problems in cardiology is that most of what we do is interpreting what are really three-dimensional data sets of moving images. So they're effectively a four-dimensional data set. And it's not that that's not tractable, but there's a lot more data to manage. And so I think the big challenge, and the challenge that Mayo is working with, is that he's trying to extract out of that moving data set something useful to say that might be new about the way we do cardiac ultrasound, for example. And I think that's a higher level challenge in a way, but tractable, but it'll take a lot of computer power to do it really well. But I think that is where we're going, and it's reason to be excited. Now, I'm proud to say that Australia's something of a leader, at least in this field, in that we now have a national cardiac ultrasound database for Australia that we all contribute to. And the study that was referred to, the St Vincent's Melbourne and St Vincent's Sydney collaboration on aortic stenosis, really was just crunching the numbers from that national echo database, and then and perhaps I can turn this into a question for our panel. Do you mind?
No, go for it.
So one of the issues that's come out of something like, which is a different approach to the one Mayo's taking, the way the National Echo Database is looking at this is that you take all of the data across Australia, and then what's interesting, what's come out of it, for example, in this common condition, aortic stenosis, which affects a lot of the population, is there are predictors have come from the AI that, as Angus mentioned, does a better job than the human reader. But we know that part of that, in the study we did in St Vincent, Melbourne and Sydney, part of that is consistency. In other words, the AI does not get diverted from the criteria that are set in the algorithm. So that consistency part. But the other part that comes out is what you call the black box problem, which is given enough data and a big enough training set, the AI will generate decisions, or can generate decision making, which was not predicted in the traditional way of inputting this. And then you've got a problem, because you may have an outcome that's performance high, but not necessarily being able to know afterwards where some of that data prediction was coming from. So to give you a great example, in this condition, aortic stenosis was common. The patients who get it tend to be old, and when the heart gets old, it malfunctions in a variety of ways. And it looks very possible that in this national database set, what we're actually reading is some of that ageing stuff and attributing it to the problem we started with. In other words, the AI has making correct prognostic decisions, but based on based on aspects of those patients that we didn't necessarily anticipate would be determining the outcomes. So it's that back readability, the ability to extract from the performance something new. If I could, I could put it that way to Angus, perhaps.
Yeah, and it's a really fascinating topic, which is this sort of bias in the data that people talk about. And I thought about this a lot, and I came to a realization that medicine is all about bias. When a patient walks through the door and they look like they come from a rheumatic fever burden population, they have a certain accent to them, and they come to you a certain way, you automatically bucket them into a high-risk piece, and that helps with the diagnosis and treatment. In fact, as a clinician, it may be irresponsible not to leverage those bias, right? Of course, we need to keep that in check because sometimes that is incorrect. You need to look at the big picture, but medicine is based on bias. But I think when people talk about this, what they're really concerned about isn't bias. They're concerned about fairness, right? They're concerned that there's certain population, you can't treat someone unfairly because they're in a certain profile or bucket. And that's solvable. So, we can't remove the bias from the data because one people call it bias, other people call it signal, right? Perhaps that age-dependent piece or other thing in the data that is biased is what make it predictive. And if, as a community, we decide that being super accurate on certain outcome prediction is going to drive better patient care and lower cost of treatment, then why not go with it, is my piece. But we need to be aware of this bias to ensure that it's still fair, such that we don't have a population who, just because of where they live or because of a certain age, the outcome always automatically giving them a inferior treatment. And that can be done, and we should probe that. But in a way, there's a finite list of what I call protective attribute, right? And at Harrison, we actually test for this. So for instance, when we look at our chest X-ray AI detection of lung nodules, we look at not only its overall performance, but we say, what is the performance in each age bracket? What is performance from every postcode in Australia individually? What is a combination of that? What is the performance of this postcode at this age group? What are different scanners, right? Maybe there's high-end Siemens scanners that only the upmarket clinic has, and then there's the more affordable brand. So we test every brand of CT, and essentially, as a clinical team in company, we come together and say, what are all of the protected attributes that we do not want unfairness? And at the moment, it's a finite list, but that can be extended, right? So what I feel like the goal shouldn't be to remove bias from the data, because bias is signal, but to measure, right, to quantify. And that's what kept me up at night. I was talking about, is there any protected attribute that we haven't thought about? And that's part of the collaboration with the user and the clinical team, is for them to come back and tell us, hey, just so you know, there's this model of the Philips scanner that is used in remote Australia that you are failing on. And we want to know about those things. Yeah.
One last fascinating person who's in the audience here is Ricky Sutton, who has had 9 heart attacks and is here to live through them all. He's also an AI specialist who has come up with an amazing thing in my industry where they allow journalists to embed videos via AI into their stories. So Ricky, tell us briefly your story, and then as someone who's been in the health system and is in the AI world, where you think it's most useful.
Thank you. Good morning. I'm a patient, so that's how I ended up here. So I started an AI company in 2014, and a couple of months later, I was getting a beer out of the fridge, and I felt lightheaded, and I had a massive heart attack. I was in my mid-40s, never been diagnosed with anything previously. And I lay on the bed for 25 minutes waiting for it to go away. Went to hospital and they said, it's not looking good. And I had 9 more heart attacks in a week. And and no one knew what it was. And it turned out to be a thing called a sarcoid. So some of you may know what this is. It's a tiny little natural growth that grew on the wall of my heart. And it created a scar. And when the electrical signal went from my brain to my heart, it got stuck in the scar and caused heart attack after heart attack. So just as a funny joke, you have to joke about it, it's a bit dark. I was trying to raise money for my AI company, and I literally did an investor call in the hat going into surgery on the bed.
Wow.
But they then put a pacemaker and a defibrillator in my chest to save me if it happened again. And over the course of a year, I had 7 more incidents where the defibrillator went off. And on each occasion, my heart rate was 250 or above. And so from that, eventually they decided that they wanted to do a major surgery called an ablation, where instead of fixing the scar, they basically covered my heart with scars. So there was only one route for the electrical signal to go. So there were no paths, there was one road. And as a result, after that, I'm now fit as a fiddle, and me and my wife and my 3 kids are enormously grateful. And as a result of that, I've been able to build an AI company, which is when you're going to get invited to an event like this and you've had a dozen heart attacks and you work in AI, you kind of fit the profile. So, thank you.
Thanks, Ricky. Look, I think we could go on forever, but everyone has to get to their other day jobs. So please join me in thanking Aengus, Mayo and Stephen for a fascinating conversation.